Hello everyone. Welcome back to another episode of Dental Digest with the Study Boards. I'm Dr. Trehan and today we're exploring one of the most important topics in oral pathology, odontogenic tumors, and we are going to specifically focus on ameloblastoma, one of the most classic and commonly asked tumors in dentistry. Now, we are going to understand odontogenic tumors first. Now, a tumor is an abnormal mass of tissue that forms when cells grow and divide more than they should. And odontogenic tumors are unique to the jaws because they arise from remnants of epithelium or ectomesenchyme, which is involved in tooth development. And they range from hematomas, which is disorganized benign overgrowth, to true neoplasms. And ameloblastoma is one of the most significant tumors in this group. Now, to understand this in a better way, we are going to go through the classification by WHO released in 2022. And this classification organizes odontogenic tumors into benign and malignant groups. Now, the benign epithelial tumors include ameloblastoma, which can have multiple forms like conventional, unicystic, adenomatoid odontogenic tumor, squamous odontogenic tumor, and calcifying epithelial odontogenic tumor. Now, I recommend you guys to pause the video here and click a screenshot of this classification because it is going to be very helpful for your revisions as well. And do understand that ameloblastoma is classified as a benign epithelial odontogenic tumor with several recognized subtypes. Now let's have an overview of what exactly ameloblastoma is. We are going to cover ameloblastoma systematically. We are going to talk about its origin and pathogenesis, then clinical features, radiographical findings, histopathology, complications, treatment, and differential diagnosis. Let's talk about origin and etiology first. Now, ameloblastoma is a benign, slow-growing, odontogenic epithelial tumor that is locally invasive and histologically benign, yet capable of extensive bone and soft tissue destruction. This is very important. And it arises from odontogenic epithelium, specifically from rests of enamel organ, dental lamina or reduced enamel epithelium surrounding developing teeth. Now, according to 2022 WHO classification, ameloblastoma is recognized in 5 major types. I'm going to show that on your screen right now. Now, let's talk about the pathogenesis of ameloblastoma. Now, it really develops from remnants of odontogenic epithelium, including rests of melissae, dental lamina, and reduced enamel epithelium. They often develop in association with odontogenic cysts, particularly dentigerous cysts. For instance, unicystic ameloblastomas are thought to evolve from pre-existing dentigerous cysts or dental follicles that are around the unerupted teeth. Now, clinically, they are slow-growing and often painless, allowing them to reach significant size before detection. And on a molecular level, mutations in BRAF and SMO genes have been frequently reported, and they activate abnormal signaling pathways that drive uncontrolled proliferation of odontogenic epithelium. This last component is not important from your exam perspective, so don't just worry about it. Now let's talk about the clinical features. Now, the most common presenting feature is painless swelling, seen in approximately 80% of the cases, typically involving the posterior mandible, and it is associated with unerupted third molars. Now, you can compare this to that of dentigerous cyst as well. Now, as the tumor grows, it causes buccolingual expansion, leading to facial asymmetry or deformities. Now, associated symptoms may really include malocclusion or periodontal problems because the tooth is going to get displaced. Tooth is also going to get loose because of periodontal ligament disruption, and the soft tissue invasion also happens in very advanced cases. Now, pain is uncommon unless any secondary infection has happened or hemorrhage occurs. Now, unicystic ameloblastomas are often asymptomatic and they are discovered incidentally on routine radiographs. Now, let's talk about radiographical features. Now, conventional ameloblastomas typically present as a multilocular radiolucency with characteristic soap bubble or honeycomb appearance. Now, radiographs may also show beach ball type buccolingual expansion, and in contrast, unicystic ameloblastomas, they appear as a well-corticated unilocular radiolucency with a single well-defined border resembling a cyst. Now, additional findings include root resorption with blunted or shortened roots, cortical bone erosion in very advanced cases, and frequent association with impacted teeth, especially mandibular third molars. And maxillary lesions can extend into the maxillary sinus, orbit, or even skull base, which requires MRI then for complete assessment to happen. Now let's talk about histopathology. Ameloblastomas are composed of peripheral hyperchromatic basal cells arranged in palisaded pattern with reversal of polarity. That is, nuclei are located away from the basement membrane. Now, central epithelial cells resemble the stellate reticulum of developing enamel organ, appearing star-shaped and loosely arranged. Now, two main histological patterns occur here. Follicular, which is the most common, that is islands of epithelium in fibrous stroma mimicking enamel organ, and the second form is plexiform, which is interlacing network of epithelial strands. Now, there are also some other recognized variants which I'm going to show you on your screen right now. Now let's talk about complications. Ameloblastoma is notorious for locally destructive behavior causing root resorption, cortical thinning, and perforation as it invades bone. And progressive expansion can cause significant facial deformities affecting function and appearance. And now a critical complication is that it is having high recurrence rate. And studies have reported that it approaches 50% in incompletely excised cases, particularly with conservative treatment rendered to them. Now, although it is considered benign, there are some metastasis that also can happen, and if it actually occurs, then it complicates the overall management and it worsens the prognosis. Let's talk about the treatment now. Now, a wide surgical excision has to be given with clear margins, which is going to be the mainstay of treatment, because we have to really focus on removing the entire tumor plus surrounding normal tissue cuff to reduce the recurrence risk. Now, for intraosseous tumors invading jawbone, resection of the involved bone segment is often required. Now, in unicystic ameloblastoma, it may permit more conservative enucleation in selected cases, but long-term follow-up is very, very important in such cases as well. Now, next is peripheral ameloblastoma. Now, peripheral or extraosseous ameloblastoma accounts for only 1% of all the cases arising in gingival soft tissue overlying the jaws. Now, it is most common found in the posterior regions. Now, I will cover this component only for the sake of the video, but this is not important from your exam perspective. Now, it predominantly involves posterior gingiva, especially the retromolar area of the mandible, with predilection for the lingual mandibular side. And when we are seeing the radiographs for this particular ameloblastoma, it may show cupping or saucerization of underlying bone, suggesting tumor pressure, though it's crucial to confirm that the lesion is confined to soft tissue. And clinically, it is usually asymptomatic. That means the patients may really notice a slow-growing gingival mass, or it's discovered during routine dental examinations. Now, treatment is surgical excision with favorable prognosis and low recurrence rate because of its confinement to soft tissue. Now, let's talk about metastasizing ameloblastoma. Now, this ameloblastoma is a rare variant where the primary tumor appears histologically benign like conventional ameloblastoma, but it has the ability to metastasize to distant sites, most commonly regional lymph nodes and lungs. And this paradox of benign histology with metastatic behavior is particularly very concerning. And these tumors typically associate with long-standing disease, often with the history of multiple surgeries or previous radiation therapy. Now, the metastatic symptoms are organ-specific, like pulmonary metastasis can happen, which can cause cough, shortness of breath, while nodal involvement presents as persistent lymph node enlargement. Now, let's talk about differential diagnosis. The first point to consider is going to be of KCOT, that is keratocystic odontogenic tumor, which presents as a unilocular or multilocular radiolucency with high recurrence, but it shows more well-defined border and parakeratinized epithelium. Then think about central giant cell granuloma, which affects mandible with expansile radiolucent lesions, but it is more aggressive in young patients containing multinucleated giant cells in the fibrous stroma. Then the next is odontogenic myxoma, which presents with soap bubble appearance, but it has gelatinous consistency with loose myxoid stroma lacking epithelial islands. Now think about dentigerous cyst, because it surrounds unerupted tooth crown with non-keratinized epithelium versus ameloblastoma's characteristic ameloblastic epithelium. Then think about fibrous dysplasia, which shows diffuse ground glass appearance with irregular woven bone and fibrous tissue. Then next is aneurysmal bone cyst, which is a multilocular lesion with blood-filled spaces and no epithelial lining. Next to think about is odontogenic fibroma, which is a well-defined lesion with scattered epithelial rests. Think about ameloblastic fibroma, which contains epithelial and mesenchymal components. Also to talk about is adenomatoid odontogenic tumor, which occurs in the interior jaws with duct-like patterns on histology. Now let's talk about the key points. needs. So ameloblastoma is a benign but locally aggressive odontogenic epithelial tumor arising from the enamel organ remnants, dental lamina or reduced enamel epithelium. Then we discussed about the WHO classification. Then we discussed the pathogenesis. Then we talked about the clinical features, how exactly it is going to happen in posterior mandible. It's a painless swelling, buccolingual expansion, facial deformity, malocclusion, and all of that. Then we talked about radiographical appearance, multilocular, soap bubble, radiolucency, while the unicystic one appears as a well-corticated unilocular lesion. Then we talked about histology. Then we talked about different complications that can happen and also the treatment options that we have. Next, we talked about differential diagnosis, which is very important from an exam perspective. Thank you so much for watching this episode of Dental Digest with the study boards. If this has contributed in your learning, please hit the like button and share it with your friends. I'll see you in the next one.